mic side.
Thank you, Dr. Bikram and AIOC for giving me this opportunity. So, when we all as a glaucoma expert know that what is the basic parameter for the glaucoma, even in even in the definition we know that it is something which is a progressive optic neuropathy, and there is a loss of something, means corresponding field changes are there according to the disc changes, in which IOP may be the modifiable factor. I'm not going in detail of this, but we know that there is something structural changes happens in the glaucoma. So previously we have, long back we have a tool like we are go for the perimetry and other thing to assess, but in recent 1 decades we have something which can detect are used as a pre-perimetric, means the changes or the damage we can assess before the actual things which happens, and since the structural changes occurs much before as compared to the functional changes, like you have seen, see the how easily are the early RNFL changes seen, then after the disc changes, then the visual field. So if you assess, anyone can assess or go by line or by find out whether if you can check the disease like glaucoma, which is a permanent blinding disorder at early stage, then we can go and treat it better. So RNFL analysis is something which is a pre-parametric where we can assess the structural changes before, and the best part is that it is not only something which much more dependent on the patient, it's the instruments, it's the gadgets, and we are observing like in the perimetry, if patient is having lot of movements, eye problems are not cooperative, then difficult. But the advantage of the RNFL analysis is the shorter times, and even you can do it as more objective, because you can usually inspect what is the optic nerve thickness is there, and again there is a quantitative estimation, means measurement is there which can help you numerical to that you can find out whether it is there. So whatever the parameters are there, we can go and analyze RNFL, optic nerve head, and the ganglionic cell complex. All these three you can use with the help of your OCT, you can detect and check, and these are the something which can help you. Just battery. Sorry for this interruption. So, so you can go and assess all these three parameters with your OCT. Again, when we are going to analyze anyone, at least know something about the machine. Until unless we know about the machine, what machine is doing and what is there. In the macular scan, you can see here a 6 mm radial line or the foveal scan. When you are going for the RNFL, then it is up to the 3 to 4 mm circular scan around the disc. And optic nerve head, you have seen here, it is a 4 mm radial line which can go. So by this way, our machine will get the data from the each and different parts of the retina. And in the Cyrus, we get a retinal map which represents 6.6 mm of the cube. That is the basic thing. We doesn't know the much detail, but at least you know what are the parameters we are taking. Here you have seen an image of normal RNFL. You have seen good even NNR level 2 and thickening, and the same thing will be reflected here in the graphical, in the graph wise, in the picture. You have seen here that is the superior, and the temporal is having, inferior is having slightly more thickness as this one, and this is the data which we are getting. If anyone is having difficulty in reading this or unable to identify this, then simply go for this RNFL thickness map. Here you have seen the double hump pattern, means here thickness is the superior and here is the inferior. This double hump pattern you will find out, yes, it is normal RNFL pattern, and again here data have been graded into the colors. Those who have in the red zone, they are having some inferior thickness. Yellow zone is having something borderline, means they are up to the normal, but they are, you can take it as a risk factor for that. They will going to be a 5% normative database, and green is temporarily 100% normal. if anyone don't want to analyze this, the beauty of this RNFL by OCT is that they represent and give you data in many ways. If you are not able to correlate your parameters with map, then go for this retinal thickness map both. If not, then at least you can go for the even, it is a average map. And here you have seen in a 4-quadrant map, means superior, inferior, temporal and quadrant. Again, if anyone want to know that in superior quadrant which clock hour or where you want to know, then you again divide it into the 12 clock hours and find out. Means in your fundus examination anywhere, if you find anything at just 1 clock hour, any RNFL or wedge defect with your slit lamp or 90D, then you can again assess that in the OCT it corresponds to same at 1 clock hour. So same parameter for at each, it is given at each and every places. Sometimes what happens, the patients come without the printout, and most of the time someone, even in the OPD, there is a habit that they will write the values, inferior 126, 121, 121. So this normal thickness is just because to know that if there is no graph is provided, no color is provided, then at least we know what is the normal range of the temporal, inferior and superior. And I simply said my resident to remember from 60 to 120. It's just a gross estimation. Means if anything below 60, it is 69 plus minus 10. That means 60 to 70. And that is 126 plus minus 17. So 60 to 20 means here is the 60 bottom and here is the 20 up. Any database where you have seen that, to remember that, that is a simple technique you can find out. I'm skipping. And these are the 7 zones. Like we go for the different zones in the HFA, there is the 7 zones for the RNFL printout which we can go. Best one is the first one, we have to check for the patient ID. I will tell you why patient ID is important. Next one is patient ID is important just because it is a normative database based on the age and the gender. So remember, if you feed a wrong age, wrong gender, then there may be some variation or the changes in your exact data. That's why the age patient ID is correspond to that. Then the normative database, that is the age wise the database, they will already system is having fitted with that, he will correlate. Then again it is one eye, then overlap with the another eye. Since glaucoma is the disorder which is slightly asymmetrical, it is not always symmetrical, so it can give you the variation in the both sequences. Again, I already explained that you can get semi-scan, quadrant or clockwise. And one thing more, those who are wish to do more research or anything, they want a percentile or ratio format. Again, this graph give you the information that what is the data and what is the format. Red-free photographs, choice of all of us, we usually go and used to have it for the monitoring purpose, it again. So here is the 7 zones of your standard printout. This one is the zone 1. Here you, if you ready, you can see the age of the patient, that is 189036. Then the gender of the female. This is again a good because sometimes what happens there, if you do RNFL and didn't save it, then in the printout you are giving the resident or the another one technician, they give the wrong printout of the same RNFL to another patient. So at least check your RNFL report with your patient's ID too, that whether it is of belonging to the same or not. This is the normative database which we have already, means machine is having for the one eye, and for the right eye this is double hump pattern, and I already explained these all the things which what is the clock hour and other thing. One thing more, by the help of OCT we can also assess the optic nerve head analysis. This is again important, and that is 100% numerical. Means it can give you an idea if anyone is doing a suppose writing a glaucoma investigation, writing the CD ratio. So it will gives you, apart from the RNFL thickness, what is the symmetry. I am telling you, symmetry of RNFL is again important. If it is there is grossly asymmetrical or difference is there, then you have to look in that eye why there is RNFL loss in one eye as compared to another eye. Then NNR, usually we all at our residency time we used to write what is NNR thickness, normal or not, thin or thick, disc area, average CD ratio and cup volume. So even all the disc parameters which we are going to write by seeing the 90D or the 20D, we can have a double check, or you can do it easily with the help of these RNFL analysis. I am skipping this side. One thing more, since ganglionic cell loss occur much before as compared to RNFL. So OCT fibers gives us one more accurate an idea about the ganglionic cell loss. So with the help of OCT we do RNFL as well as the ganglionic cell loss. You have to know these parameters this, and when we are going to check the progress like in the HFA we are doing it. So nowadays the OCT parameters are means these softwares are providing you to check the progression analysis graph too. Here I've seen this is a first examination baseline, there was no change, second no change, but in the third, in the fourth and fifth examination you find there is a red flag zone coming, means the changes started. So just like another progression or the field, if you patient lost the previously or you didn't document it, but it is saved in your system, then you can go serial monitoring of this one and check it on the system too. And progression is important. We all know that these are the pre-parametric, so it may chances that if anyone is showing progression, that it may convert to the frank glaucoma later on. There are some sources of misinterpretation when you are doing with this glaucoma diagnosis. One thing, because most important is we already said that it is age and gender match. So one of the important is the age. When you ask most of the patient what is the age, mostly they said 40 years. Either 60, 70 or 80, doesn't matter, because they remember a 40, 30 just like that. So try to, some questions are asked whether if there is dissymmetry. And another thing is that whatever our database is having, they are of the smaller normative database. But the actual RNFL variation is much larger than what we have in the machine. So it just only flag the abnormal one. Don't believe that if anyone is having slightly lesser RNFL thickness, he or she is having glaucoma or any disorder. And personally, I never suggest anyone to go on the treatment based on this basis. This is only for the screening, for predicting the future. If it is associated with high family risk, there is gross asymmetry, then the things are different. But always remember that these are screening tools. Another of the conformer is the myopic eyes. Myopic eyes usually have the smaller or the thinner RNFL. So if anyone is having, you will find out just seeing the printout, don't judge or say that is having glaucoma or not. At least ask his or her the refractive status of that. Age is again important, but although it is already mentioned and recommended, I am just putting this slide here just to know that many nowadays it is a routine practice. So down the line 5 years, 6 years, if anyone see that my previous thickness was 122 and after 10 years or 5 years he said it's 118, now you are progressing. No, at least we know that what is the rate and by what age we are progressing. Although machine put it in a green zone, but since we are measuring by the numbers, so we may confuse. So at least you know that within years there is some loss in the RNFL with the age related. So don't go for just seeing the previously. At least check at what age the previous RNFL has been done. Signal strength, that is important. Most of the time in the many BG practice, technicians are doing it and they didn't follow the signal. At least we have a good signal strength 8. If not, then recommended is more than 6. Less than 6 will have a abnormal data everywhere. So at least check. In each printout it was written signal strength 6 by 8, 10 by 8, 5 by 8, it was written. So before analysis, always check the signal strength for that. Sometimes because of the blinking or the eye movement, you will see this black type of data or something which is not. And most of the time we are confused what is this is normal or abnormal. Then simply repeat it and told the patient that don't blink here and there. These segmental errors and something is just to ensure that where we are placed. If we are going for the macular thickness and if macula is here and we are checking the scan from this area, it will not match properly. So at least in most of the 5 rastral or anywhere you have seen these 4-5 lines are there. So before making printout, at least just scroll and see at which graph or which we correspond best part of the seen part of the macula or the disc. Media opacity is again one of the conformer for this one. So in the very thick cataracts, sometimes we didn't get the good signal strength, so data is not reliable. But at least we can go for that. For the VR persons, someone is having a PVD or another thing, at least go for the some media changes or media opacity present there, because these black areas will block the signals, and in that area the RNFL thickness may change because of that. And sometimes you find out these missing datas, just like scotomas. These are not because of that. That is because of some staphyloma or something, some media opacities. Even this thickness map you can check and find out, yes, he or she is having some different types of these. These are more common in the high myopes of -8 or -12, in which pathological myopia is there and they have posterior staphyloma associated with them. Now coming to the conclusion, RNFL is having a good diagnostic availability and a great tool to screen the things. But I again repeat many times that it is not to start the treatment. It is a supplement to check, to see the something which happens in the future, and that is a more objective measurement as compared to the fields, because fields is done by the patient, and this is nowadays. Maybe in the future something else come which gives us more time bound and predicted variation with this. With these words, thank you. If any question, I'm here.
Thank you, Dr. Deepak. I understand that you have to influence your treatment decision when the fields are very poor, not reliable.
Dr. Vikram, two, three things are there. One is the non-reliability of the field. Another, I said that is if anyone is having the family history of glaucoma or anything. Because you, as you know, there is no target pressure, nothing fixed in the glaucoma. It always have a individual variation. So we have to go. But my message for the general house is that don't do treatment. If it is associated with risk factors, another thing, then judge and verify it.
So you weigh in the multiple risk
yes,
factors.
It's a multi-dimensional approach. Means what are the risk factors, how IOP behaves. If IOP is 30-20, then whether it is
you have to treat it. Yes.
Glaucomatous means changes are there or not, we have to treat. Same if field is abnormal, but IOP is changes. Sometimes you will find out the gonio changes, means creeping angle is there, another is there. In the normal tensive glaucoma, you will find out hemorrhages there. So these are the parameters which you can pick up early, and in that way it helps in the treatment and the diagnosis both. But for the normal screening purpose, it doesn't help in the treatment. It's help in diagnosis and identify the early things.
Thank you, Doctor.